Good afternoon. I'd like to start in the theory keratoplasty session. We have two keynote speakers on DSAEK and DMEK. Professor Kobayashi and Professor Kurz are very famous surgeons in the world, so I'd like to omit their introduction. Please, Professor Kobayashi, start your lecture.
Thank you. I want to first thank the program director, Professor Fukuda and Professor Shimomura, and chairs, and Professor Shimazaki and Yamagami for inviting me to give this talk. It is really an honor to be here to speak DSAEK because I like DSAEK very much. Okay. As you all know, penetrating keratoplasty or PK has been an only option for corneal diseases for more than 100 years. However, there are some disadvantages of this surgery: unpredictable topography, weak wound, and suture-related infections and graft rejections. So many clinicians like lamella surgery recently. An anterior portion of the cornea can be treated by DALK, as lectures by Dr. Shigeto Shimura yesterday. And how about the endothelium? So maybe the endothelial keratoplasty may be the goal. So many clinicians seek for the perfect EK, hopefully without corneal sutures and surface incisions. And as early as 1956, Dr. Tillet performed the first human case of EK, but this technique was very complicated and not popularized. So when I was in Bascom Palmer in Miami from 96 to 99, I routinely attend the corneal clinic and saw Dr. Carl Batterson discuss about the possibility of flap technique using microkeraton for the LASIK. But finally, this technique was very complicated and abandoned. So in 1993, this may be the first limbo approach reported by Core at the ARBO meeting. And the first breakthrough was created by Dr. Meles. So he used the air tamponade, a sutureless graft. And this surgery was called posterior lamellar keratoplasty or deep lamellar endothelial keratoplasty. So I went to the McDerry's lab and learned the DLEK, but my wet lab was unsuccessful due to the anterior perforation. So I am so afraid that I decided not to perform DLEK for human. Subsequently, Meles reported that only the descemet membrane removal is enough to perform PLK, and Price named the surgery as DSAEK in 2006. And Goroboy used the microkeraton for the preparation of the donor graft, and this surgery was named as DSAEK. Now, DSAEK is a synonym of modern EK and popularized worldwide. So, as you already know, advantage of DSAEK over PK is fast visual recovery with minimum refractive change in the structural integrity of the cornea and reduction of ocular surface complications and less rejection rate compared to PK. And it is also well known that ECD cell loss stabilizes after DSAEK after 6 or 12 months compared to PK. And recent trend in the United States is that the number of EK is superior compared to penetrating keratoplasty. This is newest data from EBAA, and the DSAEK number in the United States almost not changed around 23,000 cases, and 83% of EK were DSAEK, the rest are DMEK. And DMEK cases very increased rapidly, and now 5,000 cases last year. So how about in Japan? I do not have the domestic data, but this is the data from SightLife, which is a very large eye bank in the United States. And they ship to Japan around 1,800. and 45% were DSAEK. So maybe around 40 to 45% DSAEK in Japan now. Let's share my personal experience of DSAEK. This is my first DSAEK case performed in 2006. A graft is a little bit decentrated. Maybe I performed more than 300 cases so far, but this is only one of the decentrated graft because I don't know how to attach the graft correctly. So initially we learned the taco folding technique, and this is over 60-40 I learned, and grasp the tissue and insert it into the eye. So this is a successful case. But we found that ECD cell rate after this technique was as high as 58%, and this is terrible compared to Terrien price around 34%. So we found that in Japan we have very, very severe cases of bullous keratopathy. The Fuchs is not so common. Instead, argon laser bullous keratopathy after argon laser iridotomy are quite common, which has very shallow anterior chamber with dense cataract and weak thin donule and high vitreous pressure. The eye is very small. So this is worst case, 6th case, and 8th case in my university. This case is performed by my boss, and actually, so the donor is inserted, but after the insertion, the graft pops out from the anterior chamber. This is our 8th case of my case, and as you can see, the lens moves. Because this is not a closed system, so anterior chamber easily collapses during insertion. This is my second trial. I try to insert, and it seems almost successful, but the vitreous pressure and this irrigation is very high, and it goes out. So after experiences these problems, so I met in 2006 AAL booth seminar by Massimo Buzin. Coincidentally, he showed us the very early cases of pull-through technique. He put the graft on the conjunctiva and just pull through. So I thought I tried this technique as early as 2007 for the first time in Japan and probably for the first time in Asia. And I just put the graft epithelial side facing down and pull into the eye using the capsulorhexis forceps. And it is quite easy. And we do not have any experiences of complication after this, but we found that still the endothelial cells rate is quite high, around 50. So this is not good. So after that, Buzin developed a very beautiful, nice glide here. And I tried some, but soon we realized that the use of Buzin glide alone has sometimes trouble, iris prolapse and vitreous prolapse, because this is not also a closed system. And after that, Professor Tan developed pull-through, sheet glide assisted pull-through technique using the IOL sheet glide. And I just combined both. The use of Buzin glide and IOL sheet glide and called it double glide technique, decreased the complication dramatically with preservation of ECD as low as 22.0% cells rate after 6 months. So after trimming the IOL sheet glide with the width of 5 mm and insert it into the anterior chamber, and just pull the DSAEK graft. So no problems of iris and vitreous, and we do not care about the vitreous pressure at all. So we can do this surgery, topical, And another breakthrough is a pre-cut DSAEK system. This helps reduce the surgeon's stress dramatically. Also, many clinicians try to develop DSAEK inserters, and this is a tongue end glide. The nice thing of this glide is that this is a complete closed eye system, very sophisticated version of pull-through. Maybe many Asian surgeons like to use this after setting up the graft inside the tongue end glide and just pull through. And we have published the endothelial data of this device, and it is very good. And many surgeons also like endosaver and new cytochrome inserter, and maybe Nishida Soma DSAEK endo inserter will be available soon from Osaka University, Japan. This is an example of bullous keratopathy after argon laser iridotomy. The cataract were simultaneously performed, and the results are very good. We have performed more than 300, and most patients seem very satisfied, at least in front of me. And this is a clinical outcome of DSAEK. Maybe after 1 year, 0.84 visual acuity can be obtained, and after 1 year, endothelial cells rate is around 30%. So I just like to mention about non-stripping surgery, because in Japan or Asia, Fuchs dystrophy is quite rare, and we do not care about the good there. So we may not be need to remove the descemet membrane. So we named the surgery as non-descemet stripping automated endothelial keratoplasty, or NDSAEK. And we've confirmed in clinical case series that this NDSAEK is very useful for Asian eyes. So in terms of visual acuity, there is no change, no significant difference between DSAEK and NDSAEK. And many papers published from all over the world about NDSAEK, and all papers concluded that this non-stripping surgery is preferred option for failed PK. I'd like to show you some devices I invented. Now, this is a DSAEK marker with a diameter of 8 millimeter and dotted marker. And where visualization is very good during descemetrolysis and other maneuvers. This is 25 gauge anterior chamber maintainer. This is very thin and easy to insert, and no need to make a stitch after DSAEK. And many clinicians made DSAEK pulse forceps boosting glide. Boosting forceps is 20 gauge and a little bit thick for Japanese eye. And Dr. Tan made 23 gauge, and Professor Shimazaki made also 23 gauge. They are very good. And I also made 25 gauge, the thinnest one, with the cooperation of Professor Tan, and no need of suture for side incision. And also made a very thin 33 gauge DSAEK DMEK cannula. This is very useful to create a small air bubble during DSAEK and DMEK. And this is a recent development. The 25 gauge DSAEK DMEK manipulator with horizontal and vertical openings. So this is useful for descemet membrane stripping during DSAEK. This case has a dense corneal endothelial pigmentation. I don't know why, but maybe during the complicated cataract surgery. This is just descemet membrane scoring. And just insert the manipulator and pull the entire membrane as a sheet, like this. So it's very useful during DSAEK and DMEK. And DMEK graft maneuver is also possible using this device. I also like this interface fluid spatula using after injecting air. This device is inserted in the venting incision and just talk, and the interface fluid comes out like this. So the surgeon, if the surgeon doesn't like the venting incision, this device is not necessary. Also, this is a very large donor scleral marker for DSAEK donor, maybe useful for iBank employees. And recent development is intraoperative OCT from Zeiss RISCAN 700. And we confirmed that this device is very useful for DSAEK. So this is an image, and this is IOL sheet grade, and this is a graft. The graft is just inserted into the eye. So you can see the interface fluid even after the air is injected, like here. So this is total full, but you can still see a graft interface fluid. So after massage, you can see the air fluid will gone. So you can check your massage technique by using this intraoperative OCT. So in conclusion, currently around 45.3% of total keratoplasty are EK in Japan and 57% are EK in United States. Although several difficulties existed to perform DSAEK initially, especially for Asian eyes, DSAEK is now simple, reproducible, safe, and effective procedure for treatment of corneal endothelial dysfunction. And development of DSAEK specific forceps and inserters together with precut system make DSAEK more comfortable for surgeon. Thank you very much for your attention.
Thank you very much, Professor Kobayashi. Any comment or suggestion?
As you said, that the DSAEK becomes one of the most popular procedures in keratoplasty, and you have done a lot of cases. I would like you to ask about the influence on the surgical education in a cornea transplantation. That in an era of PK, that we started with suturing and also, trephanization. The DSAEK is so different from penetrating keratoplasty, and I wonder how the experienced surgeon educate young surgeon to master DSAEK. Do you have some specific system to educate them?
Yeah, in my university, it's a very small university, so only one or two young or colleague can learn, so there is no problem. But every year, I hold an education course at the ophthalmology meeting, and maybe DSAEK now is not so difficult. Maybe the problem is DMEK, as maybe Professor Cruz will show us how to educate young ophthalmologists.
Yeah, I agree with this Dr. Kobayashi's opinion that I educate many residents and fellows in my institute, that it seems to me that DSAEK is can be mastered easier than that in PK. That suturing is a problem, but in DSAEK it's not a big problem. Okay.
And I feel that in DSAEK or EK fascinates very young ophthalmologists compared to the era of P alone. So I think it's good for young ophthalmologists to encourage to do DSAEK.
And you're a DSAEK surgeon, and simultaneously you're a DMEK surgeon. Which one do you like?
Yeah, I like DSAEK. Yeah, DMEK is more difficult.
Okay. Any question? Okay, thank you very much.
Thank you. we are very glad to have Professor Kruse, and who is going to talk about DMEK. And Professor Kruse is kind enough to provide us two kinds of DMEK presentation. And I hear that he is going to talk in the first presentation about the more general concept and of DMEK, and second, he's going to talk a little bit more practical, precise surgical techniques. So would you start your lecture, please?
Well, thank you very much. First, I want to extend my gratitude to Professor Liu, Professor Fukuda, Professor Shimomura for the kind invitation. It's a very big honor to be here and a big pleasure to be in Kyoto, and also to talk about my favorite subject, which is DMEK. In the last talk, you have heard already the indications, and it is very interesting that there are differences between the countries in the world, with a lot of endothelial dysfunction in countries like Germany. Probably most prevalent here is Fuchs dystrophy. And then some countries where you don't have Fuchs dystrophy at all, or at least not the classic form we are talking about. So if you go to Germany, about 40% of our patients need endothelial transfer or repair, let's talk like this, and only 60% need other forms, and that is coming from data at around 2000, and now 15, 20 years later, the proportion is even changing. And you probably know that Fuchs was an Austrian ophthalmologist. He came from Vienna, but he was only describing the patients without any anatomical description. He was just saying this is something cloudy and it comes from the cornea. The person who actually described this and made the first picture is the Swiss ophthalmologist Alfred Vogt, and he made a very nice slit lamp atlas, a big book, three volumes of slit lamp findings, and he was drawing the picture by himself. So these are not photographs. You know, guttae are very difficult to image, and this is the drawing of Fuchs dystrophy from Alfred Vogt from this slit lamp book. And he was also the first to make the first anatomical description. This was a 55-year-old woman who had a corneal, who had a retinal detachment, and she was then got a cataract and secondary glaucoma, and they had to remove the eye. And from this patient, he took this classical picture showing guttae. And we have learned now that Fuchs dystrophy makes the vision blurry and changes contrast sensitivity as well as color vision due to guttata, not due to any sort of thickening of the stroma. In other words, it's not the endothelial dysfunction in terms of the pump function, but it's rather the gutta. So we cannot get along with just leaving Descemet's membrane. In Germany, we have to take this away, and we now operate much earlier, and our patients normally have a normal corneal thickness upon surgery. So this is a very nice, very short and very easy publication from Albert June in Baltimore. He operated on a patient who was a graphic designer, and as ophthalmologists, we know that we always have problems seeing how our patients see. We cannot really estimate what blindness actually means because we all see well. And this patient was a graphic designer, as I said, and you see this is Grand Central Station in New York. And this is the image after DMEK surgery. So of course, without glasses, her vision was not 20/20. She needed some refraction, but you see that the color and the contrast sensitivity in the operated eye is normal. Whereas in the Fuchs dystrophy eye, there is a lot of blurriness. And this is the major problem in our patients. They might still see 20/50 or something, but they cannot drive because of the blurriness, and they cannot read other than their computers. But if they read papers or print, they cannot do this. So, of course, we were dreaming to replace penetrating keratoplasty by something different. And you have heard already that Tillett can be credited as the person who did the first surgery in this kind, posterior lamellar surgery. And then Mellis came along with the air. And in the German or in the European context, we think it was Baracare who, a little later than Tillett, performed posterior surgery in Barcelona. And then Massimo Busin actually can be credited with the idea because he had this Academy poster. And then, of course, Mellis came along and Govery with DSAEK, and then Price and Terry performed the larger series. And then Mellis had this genius idea of transplanting Descemet's membrane in 2006. Price developed DMEK with stromal support. We did a stepwise approach, and then a lot of us were instrumental in making modification to have this surgery actually working in a routine case. So we are talking about thickness in DSAEK. There is ultra-thin DSAEK, which means that you cut with a microkeratome and you receive a transplant which is below 100 micron, and then you can just transplant Descemet's membrane. You can do this either with or without stromal support. And then even in some cases where only a partial adherence takes place, cells actually can move. And this is a very interesting idea that cells can actually move from the graft onward to the denuded stroma, which was not thinkable in the era before posterior lamellar surgery, because we all thought endothelial cells just sit there, they never move and they never proliferate, both of which is probably not true. So in essence, you know that DSAEK deals with thicker grafts, and then DMEK deals with thin grafts, which is only Descemet's membrane. So this is DSAEK surgery. You have seen this. You can use the Busin glide. It's relatively easy. You can pull the graft through, but it's not small incision surgery. You need 2 rather large incisions. You can get some astigmatism and so on and so forth. And you can use the TAN endoglide or any other device to make your life more easy. So, of course, we started with DSAEK, and we did about 200 cases. And this is like Fuchs dystrophy in Germany. And this is after you see the graft, and everything looked perfect. But when we did more cases, we also did some young patients, and we had 2 or 3 patients where the graft was perfect, the eye was perfect, the surgery was perfect, but they just didn't see well. These people just saw 20/40, 20/50, and we thought, why don't these guys see 20/20? Because they were young. They were 38, they were 42. They were not like these guys with 85 with macular degeneration and glaucoma and all this other stuff, which precludes good vision. So we said, why is this? So in our case, like in the other surgeons' experience, visual acuity came up to 0.8 because we measure in a different scale. Over time, overall it was great, but you see there are some guys down there that didn't function well. So we were investigating the relationship between the thickness of the graft, in other words, the overall thickness after surgery, and the visual acuity. And we came across the fact that visual acuity on the decimal scale and central corneal thickness were related. So the thicker the total cornea, in other words, the thicker the graft, the worse the visual acuity. And this publication, together with a publication from Ed Holland's group and Buzin, sparked a big controversy, because we said thickness matters, and especially Mark Terry, who had done so many DSAEK cases, said, no, this doesn't matter, and DSAEK is as good as DMEK, and there were other papers in favor of the hypothesis that thickness does not matter. So we said, well, is this actually true? And you know, DMEK is a little more difficult than DSAEK, and maybe in Asian eyes is even more difficult. So is this actually a good development, or is this something we don't need? Is this just for malice and some freaks? So let me explain what we did. I think if we talk about surgery, the most important thing is safety. We have been talking about keratoplastysis for 2 days, and I personally have learned a lot. This was a fabulous meeting, and you all know that sometimes patients lose their eye and then they go really blind, and safety is one of the biggest issues in keratoplastysis and in any other surgery. And of course, the biggest safety issue, and we have heard that the prognosis after 3 consecutive grafts becomes virtually none, is the safety is related to immune reaction. And 2 years ago, or roughly 2 years ago, the data from the cornea donor study were released, and they had made a big effort, 80 centers, 1,100 patients, and here we go, Fuchs dystrophy, bullous keratopathy, and endothelial dysfunction. So no Stevens-Johnson syndrome, no chemical burns, none of the vascularized scenarios, very, very easy, straightforward cases. Now think, how many of these patients did you think encounter a graft reaction after 10 years? You're wrong. It is 30% of the patients who underwent one or the other sort of graft reactions. Most of them were treated, but it's 30% every third. And if you would tell your patients, oh, we do a surgery, but you might be one of 3 that encounters immune reaction, maybe patients wouldn't like this. So if we compare our data, in Erlangen we have done a little over 2,500 DMEK cases. And they are slowly aging, so we have about 400 in the range between 3 and 4 years. You see there's virtually no transplant reaction. And that is, has been described by Price. Marianne Price did the work. And they were comparing DMEK and DSAEK and penetrating graft. You see few penetrating graft, but in the order of 600 DSAEKs with 140 DMEK. And you see PK and DSAEK after 2 years, almost 20% graft reactions. DMEK, almost none. So at the moment, we think it's 1 in 500. 1 in 500 in our cohort, the immune reaction. And consequently, we teamed up with the Prices to duplicate these numbers and to show that now we can reduce steroids, because we get a lot of glaucoma in keratoplastysis, but we also induce glaucoma after penetrating graft surgery because of secondary glaucoma in relationship to steroids. So this can be circumvented, and now the moment a patient, the pressure increase, we discontinue the steroids altogether, even if it's just after 6 weeks. We do not need the steroids anymore. So this is the data, the difference between the two groups of steroids. So the major argument in favor of DMEK is safety, because you do not or almost don't encounter graft reaction. Second, of course, is vision. What gives the better vision? And to end this controversy about thickness, we performed a study comparing DMEK with DSAEK, and we compared roughly 70 patients with the same storage and depth to preservation, same endothelial donor count. They were Fuchs dystrophy, about 10 to 15% were pseudophakic, and about roughly 2/3 underwent triple procedure, one third underwent triple, and in this cohort about 60% just the DMEK. And you see we got graft thickness in the order of 150 to 180 micron. And sure enough, you can compare the open bars with the closed bars. Closed bars is DMEK, and this is now logMAR data. And so the lower data are better vision, and the higher data are less good vision. And there's a statistically significant change. What is behind the change? The interesting fact is that the proportion of patients that see very well is much higher in DMEK as in DSAEK. In both groups, you get over 95% of the patients that see 20/40. But if you really want good vision, you have to do DMEK. The problem is that endothelial cell counts go down, and we have a little bit more detachment after DMEK. So what is the reason for this? Of course, we don't know, because in theory, DSAEK should give you good vision, but somehow it doesn't. So the really interesting fact is that we have to look at the posterior surface of the cornea. We are not trained to do this. Everybody looks to the front, and we do topography. But now, of course, we have orb scan and pentacam. We can also look at the backside, and we can perform wavefront analysis. And we have done wavefront analysis. We have been checking higher order operations in the center. And you can see that the control and the DMEK renders very similar data for the higher order operations in the center, whereas DSAEK is much higher and penetrating is about the same. So here you see Z3 to Z8 in the 4 millimeter range, and you see there is a statistically significant difference in favor of DMEK. So it seems to be that the inner surface of the cornea becomes more even after DMEK surgery, and of course, DMEK renders complete anatomical reconstruction, because you have the patients, the recipient stroma, with the new interfacial matrix. They go together, and there's no interface as in DSAEK. So we think it is more anatomically correct, and it renders better vision, and it's more safe. It is also more simple, not in terms of the surgery, but it's much more simple in terms of the instrumentation and the surgical approach, because DMEK is really a small incision surgery. You don't get astigmatism. Of course, we get some, like in cataract surgery, but normally we don't. And instrumentation costs nothing. You have the instrumentation already. So what about the data? We do have good endothelial cell count data in the midterm. You know that after penetrating graft, we have this big problem that after 10 years, almost no cells are left. There's this critical number of about 600-700 cells, 800 or 900 cells. And interestingly enough, these patients can function very well for a long time with a very low cell count. We don't know why, but this is a very worrying fact, a disturbing fact that this goes down all the time. With DSAEK, it goes down also, but not to the same extent. There seems to be a plateau. If you use the Sheets glide, Donald 10 had even better data with his TAN endoglide, and DMEK is a little less in the Mellis series, but you see these were the initial data with the rolling and the floating and all the other things during surgery. So when Mellis issued a second series, these results already became much better. The prices are still better. They are in the order of the endoglide and way above penetrating graft, and we in Erlangen are about in the middle, about the same as Mellis, which might be due to the culture requirements we are facing in Europe, because these are cold cultures and these are both, and these are warm cultures. So the drawback is a poor standardization, and I thank you for the opportunity to go into more detail in the next talk, just to lay the way of what we are talking about in the next talk. This is the surgery as is in the moment. We have to remove the Descemet's membrane. We do this under air for good reason. We have to do this under air, otherwise we miss the splitting. And then we inject the membrane with an IOL injector. And now the fun starts, because the membrane moves, and this part of the surgery is not reproducible at present. So we were taking some effort to prevent the biggest problem, which is the loss of endothelial cells due to surgeon's problem. And we admit that in DSAEK, you most of the time only need one air fill, to get the graft attached, as in DMEK in the beginning we had a lot of problems and we needed a lot of air refills. So if we are talking towards standardization, we need to talk about donor selection, about graft preparation, about how to insert and unfold the graft. Why do these grafts stick? This is a big mystery. We are working underwater, and we have to learn about endothelial cell migration, and Kyoto is the home of endothelial cell research. The world's best research is done here, and that leads to graft modification. So problem here is we have to deliver an ultra-thin graft without endothelial damage, and how you do this determines your success. So background is that the membrane always coils, curls, the endothelium being on the outside, and that if you have this in the right position, you're lucky. If you have this in the wrong position, especially in an Asian eye, is not such a nice idea to have this. So normally grafts can be either open rolls or closed rolls. The double scroll, which is ideal, almost never happens in preparation. And of course, this surgery is much more determined by the impact of the anterior chamber depth. This is not an issue in penetrating grafts, and it's far less an issue in DSAEK. But here in DMEK surgery, You do not want to have myopic eyes, and you do not want to have very thick crystalline lens or very hyperopic eyes. The best thing to have is pseudophakic eyes. You want to have a normal diaphragm. You don't want to have aphakia. You cannot do this in aphakic patients. You don't want to have iris defects, and you fear vitrectomy. Why is that? Because normally you put the graft into the anterior chamber, you unroll this, and then you have to have the edges stretched out under the peripheral cornea, like you inflate an air mattress in your tent if you're going camping. And if you have a very, very deep anterior chamber, then you can unroll the graft, but it will not stay unrolled. Because if you take the fluid out, which is the principle of the surgery, you unroll the graft and then you take out the fluid. You can do this in a shallow chamber, but you cannot do this in a very deep chamber after vitrectomy. And so the deep chamber is the most difficult thing. And this gives you the flavor how tight these rolls can be. This is a roll, 0.9 millimeter roll. It's like a roller pen. And to open up this roll with the background of a heavy pigmented eye like your patients, that is really a big problem. But I will tell you how to go around. So I think I will stop at this point because we will have most of these things in the later talks. So with this, I thank you very much for your attention. And I just want to show, can I get this back? I just want to show one idea which is important in the further case. The question comes up if we really need the graft, because now some people say if we just remove the Descemet's membrane, maybe the cells move from the center. And I want to just show you how this works. This is just a 6 millimeter mark in the center, and we fill the eye with air, and then we do a central scraping. And we just removed Descemet's membrane in the center. And in this patient, which was the only patient we did with this technique, you see that after several months, there is still a lot of corneal edema. And in this patient, we were not very happy, and we did DMEK later on, so we removed the remaining Descemet's membrane and we put in a graft. And this scenario is duplicated by Stephen Koenig, who did a couple of patients, as well as by Frank Price, who did a couple of patients that all failed, as well as by Gabriel van Rij from Holland. However, the Boston group, Kathy Colby, they, I think, Jim might correct me, but I think it's like 15 patients or something they have done. And in their hands, most of the patients clear. So maybe there is the idea of really taking this to the space age. And you all know Professor Kinoshita and Professor Koitsumi's work with the Rho kinase inhibitor. So maybe from here we start the new era without the grafts, and then we don't have to talk about DMEK and DSAEK. Thank you very much for your attention.
Okay, just one question, please.
Thanks very much, Prof. Cruiser. I'm Greg Maloney from Sydney Eye Hospital, and we, along with Kathy Colby, have for a couple of years had our decimeterexis without a graft study in operation. Mm-hmm. So Kathy's results and our results are not published yet, but we're aware of what each other is doing. I think she's done about 13 cases with a regraft rate of about 25%. We've done 8 cases with a 9th case in recovery now. We don't know what's going to happen with the 9th case, but so far we haven't had to do a salvage graft. So we firmly believe that there's a population or a subpopulation of Fuchs dystrophy who won't need a DMEK. I definitely agree with you that if you're going to do a graft for Fuchs dystrophy, DMEK is the choice. But I think the challenge that we're having now between the centres that are doing these studies is defining why some of these patients are getting better and why some are not. The 2 clues we have so far, first of all, is the morphology of the peripheral donor endothelium before doing a desmetorexis. Both Kathy's group and our group are doing genetic analysis as well, and we are finding differences in some aspects of the genetics between the patients. So we hope to publish that soon, and we'll have some guidance for patient selection, I think, very, very shortly.
Great. Yeah, I think this is an interesting thing, and we know there is a heterogeneity between the continents, and also, of course, the patients that Frank and Gabrielle and we did. These patients were also patients with just a central Fuchs, and they looked very normal, and also on specular microscopy they looked extremely normal from their appearance. So I was puzzled by the big discrepancy between the 2 groups, and it will be very interesting to follow this for the future. Thank you very much for your remark.
Okay, thank you very much for your talk. The last presentation in this session will be presented by Dr. Mohammad Bhagat Guaida.
Good afternoon, everybody. I would like to present my limited experience with DMEK in Egypt, and of course it is an honor to have my presentation after Professor Cruz. Starting DMEK in Egypt a few years ago, I really faced hard times and many difficulties in case selection, preparation, delivery to the AC, positioning and unfolding, and lastly, attachment. So regarding case selection, in Egypt, Fuchs dystrophy is considered uncommon among the Egyptian population, so I had to start with the more difficult cases of pseudophakic bullous keratopathy. And on the other side, also, this means that you will do a surgery infrequently, so doing a case once every month will result in a prolonged learning curve. The second challenge was the late presentation of cases. We don't have the luxury of doing DMEK in eyes with cornea guttata or in early stage of Fuchs endothelial dystrophy. So all eyes come in the state of decompensation with bullous keratopathy. After removal of the epithelium, you can have adequate view. I needed to remove the epithelium in nearly 98% of cases, and usually I can get an adequate view of the AC. However, some cases you can remove the epithelium and still you don't have a good view, like this case of failed penetrating graft. So you have to proceed with a blind surgery. You may be unlucky to unfold the graft, but you cannot be sure if it is in the correct site. The next challenge is the tissue availability. We have only a single eye bank in Egypt serving a population of about 90 million, so probably we have a shortage of tissues. On the other hand, we have a lot of cases of keratoconus and corneal scars, and we are doing lots of DALK. So doing a successful DALK preserving the recipient endothelium will give you the chance of using the donor endothelium in DMEK. The tissue loss occurred in 12 eyes of my case series in the early cases. In such case, the DMEK case was postponed for enrollment with another DALK case. Using imported tissue from foreign eye banks, you can have some surprises concerning the tissue you requested. Sometimes you have such a tissue with 2 corneal scars, and you should proceed in such case with surgery. You may result after peeling in a small graft than the intended to be used. I tried many methods of delivery. I used at first the glass pipette, but sometimes it did problem and it didn't fit well to the wound. And I shifted to the ICL cartridge, the off-label use of the ICL cartridge. I fitted it on a segment of an old phaco tubing system, attached it to a 5 cc syringe to create a closed system to inject the graft just by the flow of fluid from the syringe. Then I used one of the commercially available injectors. The most common I use is that by the doc. I have no financial interest in this product. It consists of a curved glass injector with a wide and a narrow side and an adapter which could be fitted to either sides and also could be fitted to a 5 cc cylinder syringe, and you can also inject the graft. You can load it in the injector by flow of fluid, and you can reverse the adapter on the other side and inject it into the anterior chamber just by the flow of fluid. Then comes to the manipulation inside the anterior chamber. To position the roll, I use gentle pulses of fluid. Care should be taken to avoid overinflating, because if pressure is too high, there is a risk of entrapment of the graft in the wound or even expulsion of the graft. I lost 2 grafts during positioning due to the increased intraocular pressure during the burst of fluid, and I had to replace these grafts. Strokes in the cornea usually helps to put the graft in the correct accessible position for the further step of the unfolding. To unfold the graft, I usually begin with the manual technique where I manipulate the graft using the spatula. This is to make sure of the correct position. Then I perform some strokes of the cornea. Sometimes just by strokes of the cornea you can totally unfold the graft. If unfolding is not possible by these strokes on the cornea, I usually inject a small bubble inside the roll and try to unfold the graft using the bubble. If it is not successful, I can enlarge this bubble or sometime inject a larger bubble to completely spread the graft over the iris. I'm enlarging the bubble. After completely unfolding the graft, carefully aspirating the bubble over the graft and re-injecting a bubble under the graft. In the post-operative period, 68 eyes needed rebubbling, 10 eyes needed twice rebubbling, 4 eyes had a free-floating graft next day post-operative. DMEK was done for them. 11 eyes had primary graft failure after initial attachment, treated by DMEK in 5 eyes and penetrating keratoplasty in 6 eyes. This is my results after 6 months regarding the visual acuity, the key readings, the cylinder, the endothelial cell density, and the central corneal thickness. At the end, I would like to present my standard technique performing the triple DMEK. I usually use the peeling technique with some modification. I use the Morim punch, which has the advantage of doing an incomplete cut. This uncut area, I use it to manipulate the graft, and also complete punching also preserve the endothelium. Yes, that's working. So the main punch leaves a part uncut, and complete punching also punches the endothelium, leaving the rest of the graft to be used in a dull case. Remove the excess of the endothelium descemet membrane layer from the periphery, and use the uncut area to manipulate the graft and to complete the peeling process. Removal the epithelium, which is nearly one of the steps of the basic steps of my surgery, using the sharpening technique to perform phacoemulsification. Planting the IOL, doing stripping or scoring of descemet membrane under the viscoelastic. Removing all the viscoelastic and performing first an inferior iodectomy. And then loading the graft in the injector. And start the process of unfolding. So, as a conclusion, I found the DMEK economic. All what you need is an ICL cartridge or any other method of delivery. No need for special equipment or instrumentation. No need for corneal graft. It has the least graft rejection, excellent visual outcome, no interface, no hydrophobic shift. However, sometimes there is a waste of tissue and high surgical skills required, prolonged surgical time, and there is relatively high bubbling rate in the beginning, and the main problem is the primary graft failure. Thank you.
Thank you. Any questions? Comment? If not, we conclude the session. Thank you.